Well, okay, so what I would do, you can always turn that off whenever you're on a break, right? And then there we go. Now we're on here. Okay. So it should be now recording everything. And then whenever you're on a break, just shut it off. And then whenever you're done, if all you have to do is make sure that's off and close both of these, and then tomorrow I'll come in and see if I can bring it in. Does that make sense?
Yeah.
Okay. So there's your.
Say hi. I think you gotta say hi.
I can't hear you if you don't say it. Let's make sure it- And you need to talk in it where it works.
Hello, hello.
Oh, perfect. Okay, I'm gonna shut that. So just when you're all done, shut that off.
Okay.
And then close all this out because it'll stop the recording then. And then I'll go back and I'll edit anything, bring it
Okay.
together, and make sure I can pull it in and post it, stream it. Okay?
Okay, sounds great. Thank you.
Yep. And I'll try to get like set myself directions for you for your
Okay.
next.
Is that enough light, guys? Okay, so respiration and artificial ventilation. What is artificial ventilation? What is it, Matthew? Yeah, okay, that's a great way to put it. It's outside help. We're having to actually ventilate for somebody. Now, Autumn, what does ventilation mean? Well, what the word ventilation in EMS, what does it mean? Yeah, it's the process of moving some kind of air, whether it's oxygenated or not oxygenated, from the atmosphere into the body, and then through a passive process where it comes back out. Because as we think about it, our chest, every one of us, we have these two really big balloons. See you tomorrow. We have these two really big balloons, and they're called lungs. So every time that we take a breath in, our lungs expand. Our diaphragm, it drops down so that our lungs can get bigger. Our intercostal muscles, they can constrict so that it lifts our ribs up and out. And then as we exhale, everything just relaxes. So it kind of goes back to that fight or flight working to feed and breed. Everything's relaxed. Now, when we talk about respiration, what's respiration actually mean? Sir?
When the oxygen and carbon dioxide actually exchange.
Good job, Tanner. All right, so where does that happen at? The alveoli. When we have that exchange, it's called the alveolar capillary exchange. So anytime you see something that says alveolar capillary exchange, it's happening in our lungs. Okay? That's where oxygen enters into the bloodstream. And ethyl methyl bad stuff, that's something to put in your notes. Ethyl methyl bad stuff gets exhaled. Now, if you look in the glossary of your book for ethyl methyl bad stuff, it's not going to be there. But does it sound like it's a good thing? No. That's all the waste products that our body has has produced. It's carbon dioxide. It's acids, potassiums, cations. These are all things that you're going to see referred to as ethyl methyl bad stuff. Now, our body itself, we actually breathe based on the level of ethyl methyl bad stuff we have. So, for example, if we hold our breath, everybody hold your breath. Take a really deep breath in and hold it. Hold it for as long as you can, and when you can't hold it any longer, raise your hand. Raise your hands up in the air. Bring them up. Bring them up. Way up in the air. Okay, why isn't everybody's hands up at the same time? How come our hands are not all up at the exact same time? Are we all different? Just a touch. We are all professionals. So our bodies function at different rates and levels. Would we all agree with that? Who do you think needs more oxygen? Larry or Arnold Schwarzenegger? Which one of us do you think needs more oxygen? Think I do? Who agrees with Jason? Hands up if you agree with Jason. Okay. Who says Arnold Schwarzenegger? Who doesn't have a clue and is like, where you going, Larry? Arnie does. The reason Arnold needs more oxygen than Larry does is because muscle mass needs energy. For it to function, it needs a lot of energy. And the only way that our body can produce energy is with oxygen. So, even though he may not breathe as fast as Larry, his tidal volume, what's tidal volume mean? Think about it. What's tidal volume mean? Volume is what? It's what? The amount that you're getting. And tidal would be one breath. In and out. Okay? That's tidal volume. What's minute volume? Okay, good job. That's how much of each breath times how many times we breathe per minute. Now, Arnold is going to take in maybe 1,000 cc's of air. Larry might take in 750. Now, the biggest reason for that is Larry's got a little extra padding and cushioning here and a little bit of adipose out here, and that's keeping my lungs from expanding as much as what his does. So I breathe more per minute than what he does, but he's using more oxygen than I do. Does that make sense? So it's not always based off of the physical fitness of somebody. It's how their body reacts. And we're all different. All right? Now, what do you think a cellular exchange is? The cellular capillary exchange. What do you think that is?
Capillary at the other end.
So it's the best way to put that. It's at the other end. Now, that doesn't mean that your cells are only at the farthest point of your body from your lungs, does it? No, because we have capillary blood vessels in what parts of our body? Every part. Where do we have cells at? Everywhere. So everywhere we have a cell, there's a capillary that goes across the top of it. Now, how big are those capillaries then? Because can we look and see a cell with our blind eye? So would we be able to see the size of that capillary? No. So just like the other blood vessels of our body, they come in different sizes. Okay? Is everybody together so far with where we're at? What's ethyl methyl bad stuff? Waste products. And how do we get those waste products? How do we develop those? It's the byproduct of creating energy. If we're just sitting here at our table, are we creating energy? Is any part of our body functioning right now? Yes. Anytime your body functions, you are in need of energy. So when you're even at rest, when you're in the feed or breed state, are you creating energy? Even though your body's rebuilding itself, is it still using itself? Yes? No? Yes. Now, we need oxygen and nitrogen for us to be able to survive. Why do we need oxygen? We already kind of covered it. It does what? It helps us create energy. Why do we need nitrogen? What does nitrogen do? What shape are our cells? Are they squares? Are they round? Yeah. If we have sickle cell anemia, they're hooked. That's bad. But they're supposed to be round in nature. What keeps the balloon or the cell open? What keeps it in that shape? Nitrogen. That should be in your notes. Nitrogen gives cells their shape. Oxygen gives our cells the ability to produce energy. Waste products are called ethyl methyl bad stuff. And that's going to be carbon dioxide, ions, it's going to be pyruvic acid, lactic acid, now I'm going to break this down. Let me know when you guys have all that little tidbit of information in your notes, because I want to make sure you get it in there. Okay, we good? Now, when we had our hands up, it's because we had to take a breath, right? That was the active phase of our body saying, we need to get out of feed and breed and we need to get into the fight or flight. We need things to work. But how does our body understand that? How did it know to do that? Any idea? And it's okay if you don't.
The amount of carbon dioxide levels in our body, the chemoreceptors send out to the brain.
Exactly. We have chemoreceptors. Chemoreceptors are what measure the amount of carbon dioxide or waste products in our system. And these chemoreceptors are located all throughout your body. There's not one just centralized location for them. They're all throughout your body. And when blood passes by it and it senses, oh, wait a second, this is dirty. This is not clean. We need to clean this up. Well, our body does that by taking a breath. And that's what helps flush out the ethyl methyl bad stuff. So that's how our body knows when we're jogging, when we're lifting, maybe we're just walking. That's how our body knows, take a breath. That's how our body knows, take more breaths than normal. It's because the chemoreceptors start picking up way too much of the ethyl methyl bad stuff. Now that's for the normal body. That's for every single one of us in here. You should have that in your notes of what the chemoreceptors do. Parker, do you have paper? Oh, okay. I'm going to ruin everything I just said. Okay? There's one particular type of patient that everything I just told you will not happen with. And that's somebody with lung disease. What happens with people that have emphysema or COPD or chronic bronchitis, these are caused from smoking, from your environment. You know, maybe you work in a factory and it's steam filled, and inside of that steam is all kinds of byproducts off of the product that you're making, and your body gets accustomed or gets all of that into its system. Or maybe it's a coal mine. Maybe you are an auto mechanic and you're constantly breathing in brake dusts or even tires, that sort of thing. With those types of patients, your body gets so accustomed to having the bad stuff in it that now it converts away from reading the ethyl methyl bad stuff to reading the amount of oxygen that's in your system. It flips it. So, what happens with these people is because they have this buildup of the ethyl methyls, and it takes quite a while to happen, they wind up holding air in their lung cavity. And after doing so, think about yourself. Everybody, again, take that really deep breath and tell me what happens to your chest. What's your chest do? It gets bigger, right? It kind of rounds itself out, doesn't it? Because these breathers hold a lot of oxygen in their lungs. They get what's called barrel-chested. Okay? So when we come into somebody's house and we look at them and we can see that they have just this chronic, no, I'm not short of breath. And we look at them and we see that their chest is barrel shaped or really round. That tells us right away this is an emphysemic type patient. So, old school thought with these types of patients, because what tells them to breathe is the oxygen level. Old school thought was if we give them too much oxygen, we're going to cause them not to breathe, because their body likes what? The ethyl methyl bad stuff. And every time they get oxygen in, what happens to the ethyl methyl bad stuff? Does it switch? Yes, that's the alveolar capillary exchange and the cellular capillary exchange, right? Even emphysemic patients have that. But they only know to breathe when their oxygen level is really low. So the old school thought was if we increase their oxygen level, that would knock out their respiratory drive and we're now hurting them instead of helping them. We're going to take that away. That's off the table. All right? We will, if they need oxygen, we will give it to them. Okay? Now the reason I tell you that is because you'll get some old-time, crotchety-ass old paramedics that'll look at you and go, what are you giving on non-rebreather for? You're going to knock out the respiratory drive. Well, it might be the case, but it was probably going to happen anyway. So if the patient needs oxygen, we're going to give it to them. But we're going to use our tools to help us know when and how much oxygen we should give. So, what do you think those tools are? How can we look at somebody and tell they're short of breath? How can we look at somebody and tell they're short of breath? I am. How can we look at somebody? We can see it. We know what somebody looks like when they're breathing normally, right? Anybody ever seen a dead body? Okay. Hey, Zach, do dead bodies breathe? What if you stare at them for a long time? They still don't breathe, but what does your mind say? It says, "Ooh, did that person just take a breath?" Because your head thinks, "Oh my gosh, they're supposed to be breathing," but they aren't. So we can look at them and see. We can look at the signs that tell us, hey, this person is having troubles breathing. They have really active chest muscles, or they have the seesaw breathing with their abdomen, or their neck is flaring, or their nose is flaring, especially in children. So we have to look at our patient. What color is their skin? Are they blue? Are they pale? Are they jaundiced? And when I say we look at the color of their skin, I'm not talking about are they Native American, are they black, are they white, are they Oriental. What I'm talking about is pink, pale, cyanotic, or ashen, even flushed. So when we talk about color of skin, that's what we're talking about. Now, we have a couple of fair-skinned people in our class. How do we know that Snoopy is fair-skinned? How can we tell it? Just by her walking up here and standing in the light. Okay, red hair, almost a definitive giveaway. People that have a lot of freckles, the underlining part of their skin is very fair. So how can we look at Tommy and go, she's cyanotic, or she's pale, or she's even flushed? The simplest way, look at the class, just relax, is I want to pull her eyelid down or pull it up, and I want to look on the inside. Thank you, ma'am. I want to look on the inside. If it's pale or white, she's pale. If it's nice and bright red, she's probably flushed. If it's a pink color, she's in homeostasis. So how about somebody who is extremely dark pigmented, whether they're Middle Eastern or maybe they're black? How can we tell if they're pale? Yeah, you can peel down any mucous membrane and look at it and see. The exact same method. Let's pull their eyelid down. Let's look to see what color it is. Maybe look into their mouth. So these are some key assessment tools. Now, one thing that a lot of people would jump right to doing, and I'm going to tell you not to do it as your first line treatment. A lot of people will jump in the ambulance and the first thing they reach for is something called a pulse ox. If the pulse ox reading is low, it was low 2 minutes ago. When should we have noticed that they were having respiratory trouble? The 2 minutes ago. Pulse oximetry is a tool that shows progression. It's not a tool to use to show immediate assessment. Does that make sense to everybody? Pulse oximetry, it has its place. It should be used, but it should not be the first thing that you use to assess somebody that is a respiratory patient, because you're behind the 8 ball if you do. Sir?
So, would you use the pulse ox to determine if you're going to apply oxygen, or do you use the physical assessment?
Physical assessment.
A lot of places will tell you, 94 is that magic number. Anything under that, they need some type of oxygen.
That's a true statement.
Yeah. But then the question becomes, like, if you can look at somebody and assess them, like, how much do you know to give them, right? So, take for instance, they're at, say, 90, 92, probably a nasal cannula of 4 to 6 LPM. Do the trick, right? If they're, say, at 82, then they're going to need a lot more, obviously. Can you physically look at somebody and make that distinction?
Let me ask you this. If I'm really sweaty and I'm pale and I'm going, or I'm maybe even wheezing, or I sound like I'm breathing through a bunch of bubbles, do you think I just need 2 liters of oxygen? Or do you think that I probably need more?
Well, if you're just short of breath.
I threw out a couple examples for you.
Yeah.
I'm pale. Is that normal?
No.
I'm sweaty. Is that normal? And I'm breathing with audible sounds. Is that normal?
No.
So that's the person that we should be able to walk in right away and go, nope, need to put them on oxygen, and this is what I want to use.
Well, to me, that's a given, but how much is the question?
If they're having, is that somebody that's having a lot of trouble? Go high. We can always back down.
Start with so in that particular instance, would you start with nasal cannula?
Nope, I would go with a non-rebreather. That person that is making sounds to breathe, I would put them on a non-rebreather.
Okay, on 15 or like 8?
Well, and we're going to talk about that. With a non-rebreather, how do we know what the right setting is for the O2? There's something that happens when they take a breath. does the bag deflate completely, or does it stay inflated with their breath? If it stays inflated with their breath at, say, 10 liters, and they're taking a good breath down, that's okay. We can leave it at 10. If they deflate the bag completely, then we need to turn our oxygen up, maybe go to 12. And if it still deflates down, then let's go to 15. Okay?
What if it's like a 15?
Then you might need to look to start bagging them. There's something else that's going on. Or they're not having a respiratory problem, they're having a behavioral problem. And that's hyperventilation. Now, when I say hyperventilation is the behavioral problem, I'm not saying that, okay, everybody that hyperventilates is cuckoo. That's not the case. But we need to evaluate that. Did that answer your question, Jason?
Does it make sense about translate?
I think so, yeah. Yeah? Does anybody have a question based off of that? All right. All right, pathophysiology and physiology, ventilation, that's the process, like we said, moving air in and out. With every breath that we take in, our chest muscles are going to contract. Our intercostal muscles are going to contract, that's going to make our chest go out. Our diaphragm, it's going to fall down, and that's going to cause our lungs to be able to expand even further. Exhalation, very passive process. Because there's a change in the pressure inside of the thoracic cavity, that's what's going to pull your diaphragm up. And then as your thoracic muscles or your intercostal muscles relax, that's going to allow the lung tissue to collapse down. Tidal volume, it's the amount of air that we bring in one breath. Minute volume is? Good. Ventilation, it's designed to move air into the alveoli for the gas exchange. Now, we can be taking a breath, and it may be something called an agonal breath. And what happens is we only move air into the dead space. The amount of space that you have from the opening of your mouth or your nasal passage all the way down through your trachea to where it bifurcates or it creates what's called the carina. That's all dead space. That oxygen itself does not get utilized. In an agonal breath, one that is very slow and is more of a kind of breath, that's the one that we have to ventilate for. Alveoli, they form the ends of the bronchial tubes. They're bunches of sacs. They're inflated and ventilated as air moves in and out. Do we have a pretty good understanding of that? If somebody doesn't get that, now's the time we need to talk about it. Each alveoli, it's a bubble-like structure, and those bubbles form together to make a grape-like structure. Pulmonary capillaries bring blood close to the sacs. The thin alveoli capillary walls allow gas to exchange, and that's called the what? That is respiration, but it happens at what point? What is that called? It begins with alveolar. Good job. Oxygen goes into the blood, carbon dioxide, as well as other ethyl methyl bad stuffs come out. Diffusion. This should be in your notes. You should have this highlighted. It's the movement of gases from an area of high concentration to an area of low concentration. That's called diffusion. When we talk about pulmonary respiration, that's the act of alveolar capillary exchange. Cellular respiration is where we have the cellular capillary exchange. So at the alveolar capillary exchange, what goes in the blood? What goes into the blood at the alveolar capillary exchange? Oxygen. Guys, it's okay. Say what you're thinking. If it's wrong, that's okay. We'll fix it. It's oxygen goes in. What comes out of the blood? Ethyl methyl bad stuff. When we get to the cellular exchange, the cellular capillary exchange, what's happening there? Oxygen goes into the cell, carbon dioxide comes out of the cell. Why does oxygen need to go into the cell? Produces energy. In order for pulmonary and cellular respiration to occur, respiratory and circulatory systems, they all have to work together. So air has to go in and out, blood has to go round and round, and there has to be a closed system. Okay? If we just push air in, is it going to come back out? Yeah, because there's going to be a pressure difference. But is it going to be forced into the alveolar sacs? No, because the blood's not going round and round. So unless we have an intact circulatory system, then we cannot have oxygenation, or another key word that you're going to hear a lot, and it's called perfusion. All right, I want to take a couple minute break. At this point, we've been going for an hour. I want you guys to get up, get a little blood flow. All right? I don't think you can. But we can.
Somehow they do it. I can't do it. It's the low ones here. Yeah. Not the bright white ones. Just these ones. Okay. I know, I can't see.
I know, me too.
But it's you. Yeah. I mean, if everybody would rather have them off, I don't know.
No. Well, this will be all right.
Yeah.
I'll be right back.
What's going on, Zach?
Oh, no.
You're on the playground. You went in the battle today. Said you went in the battle today.
No, I did not.
You got on your shape today?
No, I got here 5.
Oh, okay. 5, it seems like you might cover them for somebody. That's fun.
More money.
Yeah, Christmas is coming. Get them presents for the kiddos.
Well, they went green,
What does that mean? We're go on that, and then,
no, red was all the way down in the schoolhouse. Yeah.
the thing,
Yeah, they called me for me.
what?
Called him and they were like, I was talking to you, man, raised, I was, one of the office academics in my class, and then just,
So that made you just, you know, like, shut my 5 feet.
I guess, yeah, I was at direct line between airmen and NCLs, I was
Yeah.
at middle ground.
We call him class leader in the Army. Nobody ever wants to be the class leader, because when some shit happens, it's always on you.
Well, it's the Air Force, so.
Yeah.
Yeah, no, I had, when I became an, airman leader, I had like no carpet on my back.
You what?
I had zero carpet on my back. They actually kind of left me alone. Sergeant Airman Lewis.
Is that excellent?
Yeah. 6 months.
Long time.
Yeah. Well, half of it was just learning ACDC.
ACDC.
Yeah, sure. The electrical ACDC. Then the other half of it was, radios, radar.
It's a long chapter. There's a lot to it. But the test score wasn't that bad.
Yeah, almost. There's something about like 40-something questions on 3 bits.
49. Yeah.
How long did it take you?
About a half hour, and they go long. You have to look up a lot of people. You're saying it's not that bad. Good.
Is anybody hot?
A little bit.
Oh.
Big shock. Okay. I know Jimmy John's delivers. I say Jimmy John's delivers. I've heard that's pretty quick. It's kind of freaky how it happens. All right. We back? So, Colin,
Yes.
what happens at the cellular capillary exchange?
Gases exchange.
What gases?
Well, you got oxygen and then ethyl methyl pads.
Okay, Tanner, what's ethyl methyl bad stuff?
All the waste products, the body creates all the
What are some of those waste products?
Carbon dioxide, your ions, and acid.
Okay, good. What happens at the alveolar capillary exchange? Jack.
oxygen goes into the blood and carbon dioxide pulled out.
Just carbon dioxide?
All the other waste products.
Autumn, is breathing a active or passive action? It's a trick question. It's both. But for us to bring air in, it's, and for air to go out, it's, why is that, Parker? I don't want to put the pressure on you here. I don't want to add any negative pressure to you here. Well, yeah, it gets rid of all the bad stuff, but how does it happen? Why does the end of a breath, why is it passive? Matthew, help him out. It relaxes, or it is a negative pressure inside the lungs. When we breathe, it creates positive pressure. When we exhale, it's a negative pressure. I kept trying to hint you there with no pressure, negative. All right, mechanical failures of the cardiopulmonary system, they limit the ability of the chest to create pressure changes. So, if we're supposed to have a closed system, meaning our pump, meaning our circulatory system, and meaning our lungs, where's the only acceptable hole in that whole system? Trachea. So air's supposed to go up and down, and that's okay. But blood is supposed to go all around, but it's supposed to stay inside of its system. If there's any breach to that, is there going to be a change in the way that air circulates? Yeah. One of the worst places that we can have a hole is in our lungs. Because if we wind up with a hole in our lungs, and Autumn, I'm going to touch you for a second. If we wind up with a hole right here, or guys that can't see on this side, a hole right here, what's going to happen every time she takes a breath in? It's going to fill the pleural space. Well, what's the pleural space?
The lining of the lung.
The outside protecting, or the cellophane covering. Yeah. So you take a breath, and you're taking enough breath in so that it fills your lung, but since she's got that hole there, some of that air is going to just kind of seep out, like water running out of a hose that's got a hole in it. Air's going to do the same thing. Well, that cellophane, or the pleural space, or the protective covering of our lung, it's really not cellophane or cling wrap. It's very similar to it. That's not going to give. That's not real stretchy or spongy. So every time some air escapes, what's going to happen to her lung tissue? Tommy, I don't want to push you here, but what's going to happen to the lung tissue? I don't want to push the answer on you. It's going to push it back away from where the air is coming out. So now, instead of the lung getting really big, now it just gets a little big. But this pocket of air stays there. And then every time we take a breath, that pocket of air gets bigger and bigger. And every time we take a breath, Tommy, stand up for me. I want you to stand right here. Stand steady. Every time we take a breath, our lung is doing this. Well, I'm one lung, she's the other lung. What's happening? Parker, come stand right here. I want you to be right here. Turn around. Come back. Half step back. Every time I push this way, where's she going? She's not moving? Okay. Every time I push this way, she's going to move. But guess what else is going to move? And now all of a sudden, is he going to be able to pump the way he's supposed to? So by having, thank you guys, go ahead and sit down. By having an opening in our lung, it not only affects the amount of air or tidal volume or even minute volume we can bring in, but it affects the stroke volume of our blood circulating. When we say stroke volume, that's the amount of blood that's moved with one contraction of the heart. We're going to lose nervous control. It makes it impossible for interactive respiratory muscles to work, meaning they're being collapsed down. They can't expand out the way that they're supposed to. Your diaphragm's not going to be able to work because it's getting pushed to the side. And if it happens to tear, which can happen frequently, what's all down here? The what? The good stuff? Well, you've got your liver, your spleen, your gallbladder, your kidneys, your pancreas. That's all in this area. And down below your umbilicus, that's all of your intestines. And your intestines, they're like just pushed in. And God said, man, I don't care. Get in there. And he just kept cramming them in and cramming them in and cramming them in. So there's all kinds of pressure built up around those. So when this tears and it allows some of that pressure to come this way, what do you think's coming up into the lung cavity? All of this stuff will find its way up into the thoracic cavity. We talked about what? Am I going backwards? Oh. Like, wait a minute. All right, so now we're going to get into respiration. We talked about that. What is respiration? Tanner?
I don't think we know this one.
This one? Circulation issues prevent blood from carrying enough oxygen? Didn't we just say that? Okay, but I said it. We'll go over it. Significant blood loss reduces the amount of blood circulating to the alveoli. Does that make sense? Yeah? Insufficient hemoglobin or hemoglobin that is not working properly limits the transport of oxygen. Now, I didn't say that, so good pickup. Hemoglobin is what carries the oxygen throughout the blood. So it has to saturate the red blood cells so that it can circulate throughout our circulatory system. If we lose blood, we lose red blood cells, we lose white blood cells, we lose plasma. What's plasma? It's the waters of the blood, right? It's what carries all of the different cells. It's kind of a yellowish or a clear, sticky, kind of pasty kind of thing. So, respiration. How do we know we have respiration? And what's another word for respiration? A good word. I told you you'll hear it frequently. Colin? Perfusion. So when we perfuse, we should all be pink, we should all be warm, we should all be dry. So I want you to reach to the person sitting close to you. And I want you to pull their eyelid down. And I want you to look at their eye and tell me what color you see. Go ahead. I pulled yours down. You didn't see his and he didn't see yours. Okay, the next thing I want you to do is take the back of your hand and I want you to rub it across the person's forehead. And tell me what you feel. Have you got a chance to do anybody? You can't see your own eye, you ding-a-ling. Go do it with Tommy since she was being obtuse. Go get her.
She can travel with
Okay. It is hot in here. Okay, the next thing I want you to do is I want you to think about what, whether the skin was wet or dry. When you touched it, you felt whether it was warm or cold, right? Was it wet or dry when you touched them? Was she wet or dry? When you put your hand here, did you feel water? Okay, so her skin is, yeah, she needs to invest in a little bit of lotion,
Well, it wasn't
right?
dry.
Oh, it wasn't crusty.
No.
Okay. If it's moist or you see little beads of sweat, especially in places like the forehead, the palms, the groin, the underarms, those are the fastest places to sweat. Okay? And you'll have quite a bit of sweat in those areas. One of the last places on your body to sweat and the first place that will dry up, forearms. So when you assess somebody, look at their forearms. If they've been sitting down and relaxed for upwards of 5 to 10 minutes, if they're in homeostasis, should their forearms be sweaty? No, it should be dry. So we come up to somebody and we look and it's like, they got sweaty forearms. Let's look at the rest of them. Maybe they just got out of the shower. That's a possibility. But let's look at those key areas to see if they're sweaty. If they are, we've got a problem with perfusion. Okay? So if we have a problem with perfusion, where do we have a problem at and what do we need? What's the first thing we need? Oxygen. Okay? Because what's happening when you sweat is your body is pushing out ethyl methyl bad things. So that's why people sweat. Now, do we need a complete pulmonary system as well as an intact circulatory system? Yeah. If there's any breach to either one of those, what do you think is going to happen to our respiratory rate? What do you think the chemoreceptors are going to say? Jack it up. Let's start breathing a little harder. So when we come in and we find our patient and they're a little sweaty and they're breathing about 28 times a minute, how long should it take us to see that? When you look at somebody and they're going, is that normal? What do we know just by seeing that? Got a perfusion problem somewhere. So we know they need oxygen. How long did it take you to realize that I was breathing fast? Seconds. How long did it take you to see that I was sweaty? Seconds. How long should it have taken you to say to your partner, hey, let's get a little bit of oxygen started here at this liter amount? How long should that take you? Seconds. We haven't done anything else in our assessment, but we know that they have a perfusion problem or a respiratory issue. Brain and body cells, they need a steady supply of oxygen to maintain normal function. We know that there has to be oxygen to go into the cells, and that's what causes the cell to produce heat, which in turn produces energy, which in turn produces lactic and pyruvic and cations and carbon dioxide, and those are also known as ethyl methyl bad stuff. Hypoxia is a low level of oxygen. When you come in and you find somebody that's very pale or cyanotic, what color do you think cyanosis is? blue. When you see that their fingernails have turned a little dusky or a little shade of a light blue, or maybe the bottom side of their lips are starting to get a little discolored, they're not breathing enough. There's something that's causing a lack of oxygen. They're hypoxic. Okay? Hypercapnia, it's a high level of carbon dioxide. With high levels of carbon dioxide, we're going to see, one second, we're going to see pallor. We're going to see maybe cyanosis. We're going to see a decreased respiratory rate or a very slow respiratory rate. Or there's one other type of patient that we might see hypercarbia with. Or hypercapnia, sorry. Yeah. COPD. What was your question? Is that it?
So if you're hypercapnic,
Mm-hmm.
right,
Mm-hmm.
would that also lead to hypoxia?
It will.
So you could maybe see the same symptoms for either one of them.
You will. Very much
Both
so.
the same? Or you have to identify what
Well,
else is going
you're
on?
not necessarily going to have to differentiate the two. You just have to know that they are simultaneously going to be there.
Okay. Fair.
Okay?
You treat it fast anyway.
Yes. Yes, ma'am. Pallor, being pale.
Oh,
Oh, excellent question. Excellent question. So, assess the cardiopulmonary system. How can we do that? How do we assess the cardiopulmonary system? Let's get back with our groups again. I want you to take 2 fingers, and I want you to reach right up here on your partner, and I want you to feel for their carotid pulse. Go back there with Zach, if you would. So, going to feel for a carotid pulse. Everybody find it? It's very easy to find on yourself. It's not always easy to find on someone else. You won't feel it on a dead person. Hold on, don't go nowhere. The next thing I want you to do, take those 2 same fingers. You notice that I've never used my thumb. We're going to use these 2 fingers all the time. We're going to feel right here on the thumb side for our radial artery. Do it on your partner. It's easy to find on yourself. Okay. Now, the next thing I want you to do, you're going to have to do this one at a time. I want you to take 2 fingers on your left hand and find a carotid pulse. 2 fingers on your right hand, find a radial pulse of your partner. Yep.
I'm terrible at pulse.
Just relax.
Oh, it's forward. Okay.
Hold on.
This.
No, it's there. It's right here. Now, as you're feeling that, keep your finger on there. Keep your fingers on there. You don't feel it? Did you feel it on him? Come up here to me. Come up here.
I can't. I don't know. I'm sure there's something wrong with my
Right here.
fingers.
Come down. Soft. Soft. Now, gradually push in. And then up a little. Just gradually.
Oh, yeah. I
Okay.
feel it now. Yeah.
Start soft. Start going in and up just a little bit, and you'll feel it. Now, as you're feeling those, what you're feeling for is that they feel the same. The rate feels the same. The strength feels the same. The volume feels the same. Okay? If they're not the same, do you have an intact circulatory system? No. Something's wrong. It might be a problem with the pump. It might be a loss of volume. It might be that you got scared. Because what happens when you have that fight or flight? What happened? What just happened to your body? You got startled. Your blood vessels constricted. Your respiratory rate went up. Your body said, oh, I'm scared. Fix it. And that's going to make you breathe harder, beat harder, and higher pressure. But how long does that last? Seconds. But if you have a problem with your circulatory system, does it just go away on its own? Did I scare you? No. Will it go away on its own, or does it need to be fixed somehow? Are we going to be able to fix a circulatory system that's broke? Pre-hospital. I got to remember to stop hitting this thing. Crystal's going to have my hide when she starts listening to it, especially when I yelled. But we can manage it. We can't fix it. We can manage it. All right? How we manage it, we're going to get there. We're not there yet. Cardiopulmonary system fails, the body compensates for hypoxia and hypercapnia. The chemoreceptors, we talked about what those are. They stimulate when there's a lack of, for who? You said oxygen, right? That's a true answer, but for who? Nope. Colin? It will read oxygen for our lung disease patients. And that's why they get the barrel chest, because they're holding air in. So what does the chemoreceptors read? What are they reading? No, you just answered. Carbon dioxide. And as it reads and it says, I've got too much carbon dioxide, what's your body supposed to do? Breathe more. Yeah, is it going to breathe deeper? Maybe a little quicker? Yeah, it should. And as it does that, it's going to help to get rid of the ethyl methyl bad stuffs. And then once your body starts reading the right levels of carbon dioxide, then your breathing will go back to its normal state. So respiratory distress, we talked a little bit about this. This is where you look at somebody and you see they're not breathing normal. Something doesn't look right about the way they're breathing. It can be fast, it can be really slow. It can be really deep, it can be really shallow. It can even be fast, 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 shallow. Shallow, shallow, fast, 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 shallow. That's what's called Cheyne-Stokes breathing. Or it can be just a really deep, constant. What's going to happen if I keep doing that? Yes, because my body is going to have too much. No, I'm going to get rid of too much carbon dioxide. Damn, it's kicking in right now. I'm getting rid of too much carbon dioxide and have too much oxygen. That's called hyperventilation. Now, that falls to the behavioral side of respiratory problems. But does that mean that it's a cuckoo bird because somebody's hyperventilating? No. Any one of us in here could go into a hyperventilative state for an ungodly number of reasons. I don't think anybody in here is Cheerio for Cocoa Puffs. So, another thing that will cause hyperventilation is what's called Kussmaul respirations. The difference between a Kussmaul respiration and hyperventilation is how deep they come in and the smell of their breath. What they're doing with Kussmaul respirations is they're bringing in a lot of oxygen to try to fight off a lot of acids that are built up in their system. And it's caused from undiagnosed diabetes or untreated diabetes.
So the breath smells crude.
It will smell like an acetone. Yeah, you'll see books that'll say it smells like juicy fruit gum or it smells like fruit. I personally have never smelled one that smelled pleasant like a piece of juicy fruit gum. I mean, it just kind of smells like ass. Yeah.
So that, you say, too small?
Kussmaul.
Spell it?
K-A-U-S-M-A-U-L. Kussmaul. Now, respiratory distress. That's the person that, you know, maybe they just ran around the building, they came back in, and they just got done with their workout, and they're, oh, whew, man, that was good. Feel good right now. And as they relax, their respiratory rate goes back to normal. Or maybe it's just Larry walking up the stairs. Yeah. That's fixable. That's changeable. Respiratory failure is now where they're having a collapse somewhere. This is a dire need. This person is about to go into either respiratory or cardiac arrest. Their body is shutting down. They're not able to read at the chemoreceptors any longer. The body has stopped working. Our body is inherently lazy. That being said, any person in this room right now, if we would sedate you and start breathing for you with a back valve mask, guess what your body will do? It will stop breathing. Because we're lazy. It knows, hey, somebody's breathing for me. I don't have to work. I don't have to do this. So it will shut down. The person that's not intubated or sedated, that happens to them when they've worked excessively hard. Maybe they have congestive heart failure and they've got fluid that's built up into their lungs, or even fluid in their legs that their heart is trying to push the volume through their body. And they get so tired because they've worked so hard to just breathe that they just don't have any strength anymore. They just fail to perfuse. So any question about what the two of those are? Which one is worse? Respiratory failure is worse. Respiratory distress, that might be the asthmatic that's telling you, you know, hey, I can't breathe. I can't breathe. I need a treatment, or I need some oxygen. And we can calm them down with some treatment. And we can bring things back to homeostasis for them. But if they get into respiratory failure, that's the asthmatic that has gone so long without having help that now they're just grasping at help. And their body is saying no, no, no. So respiratory distress, with respiratory distress, you'll have what's called respiratory acidosis. Now, we're not going to get real deep into respiratory acidosis versus metabolic acidosis, but we have to have a general understanding of it. For our body to work, and these numbers should be in your notes, because you will need these numbers. For our body to work sufficiently, we have to have a pH level of 7.35 to 7.45. Now, right underneath where you wrote 735 to 745, I want you to write 35-45. And then before it, write CO2. What's CO2? It's carbon dioxide. Our body routinely will have carbon dioxide in it. The level of acceptable carbon dioxide is 35 to 45 millimeters of torr.
What is that?
Not a clue.
That's just how you read.
That's-
How you read whatever.
Yep. So, if we have respiratory acidosis, we have too many ethyl methyls, right? Because we said ethyl methyls are acids, correct? So we have too many acids. So what's that 3,5 to 4,5 number going to be? Is it going to be below 3,5 or is it going to be above 4,5? It'll be above it. So say it's 50. Now we know a normal pH level, which is what reads the acid-base balance. Acids are the lower side, bases or alkalis are the higher side. The neutral on an acid-base balance scale is 7.0. If our normal pH is 7.35 to 7.45, are we a little acidic or are we a little alkalytic? We're a little alkalytic. But if we have respiratory acidosis, we know that our CO2 level is going to be up here, right? Where's our pH level going to be? It's going to be below the 7.35. It's going to be maybe 7.2, or in extreme cases, 6.7. 6.7. Oh, come on, man. I had to work for that joke. Sorry, Crystal. So, it's going to be to the lower side, right? Where do you think our respiratory rate is going to be in respiratory acidosis?
I would assume higher.
Or,
Oh boy.
nope, not oh boy. Okay. If you're breathing 4 times a minute, are you going to have a buildup of carbon dioxide?
Yeah.
Are you going to have a buildup of acids? So are you going to have a high level?
Of acid buildup, yeah.
Okay. So can it be low? Respiratory failure or respiratory distress, can it be low? Low breathing? Sure. How about if you have a respiratory rate of 52? Is that normal? That's a breath about every second. I want you to try to take a breath every second. Right now. Take a breath every second. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. Were you able to do that? No, not really, because air didn't go all the way up and down inside of your lung cavity, did it? It probably only filled that dead space area. What's the dead space area? From the carina, or the bifurcation, all the way up and out. So somebody that's breathing a very fast rate is probably breathing too shallow. So are they moving enough air? No. Now, can somebody be breathing, and the normal respiratory rate is 12 to 20 for an adult, right? We learned that, right? So 12 to 20 breaths per minute for Arnie Schwarzenegger. You think he's going to be higher on that scale or lower? Yeah. He'll be lower unless he's at work or working out, then he's going to be excessively higher because he needs more energy, right? So how about Larry? Am I going to be at 12 or am I going to be closer to the 16, maybe 20? 16, maybe 20. So if I'm not moving air in and out nice and deep, do I have a lack of oxygen? Yeah. So when we look at somebody and we think about respiratory distress, we need to look for these three things: rate, depth, and quality. The rate should fall between 12 and 20. In a matter of seconds, can we look at a person and tell whether or not they're breathing in that time frame, that 12 to 20 rate? Probably. Will we have an exact number? No. But can we also look at them and go, oh my gosh, man, you know, Snoopy, she was just trying to breathe 50 times a minute. I know that's not normal. Or I go back here to Colm and he's breathing 4 times a minute. And I know that's not normal. And I'm going to see the same types of problems. So the rate is going to tell us information about ventilation. Okay? Depth. Now how deep are they breathing? Do I see a nice rise and fall of their chest? And is it symmetrical? Does one side rise and the other side fall down? Or every time they take a breath, do they kind of lean and guard to that side like, oh gosh, that hurt? And in quality, that's the sound that they're making. Every one of us in here should be breathing very, very freely and easily. There shouldn't be many sounds when we move air in and out. But if we have a problem such as maybe we're a smoker and we're trying to laugh. Anybody ever heard a smoker's laugh? Sounds really kind of gnarly and crispy. Right? That's because they have a buildup of mucus that falls within the cilia or the hair-like structures that are inside their trachea. And that mucus, when they try to laugh, it starts to shuffle a little bit. Or maybe they have a cold and some bronchitis that's starting to build up and they get these mucus plugs. Or the asthmatic that gets the mucus plug. That every time they try to take a breath in, the air goes in, but as they try to exhale, now all of a sudden that plug is plugging up the airway and the air doesn't want to go out. So they have to force it out. So with respiratory distress, how are we going to fix it? How are we going to fix those numbers? The low pH level and the high carbon dioxide level. How are we going to fix it? Somebody else. What's going to fix high carbon dioxide levels and low pH levels? We know that it's based off of acids. What fixes acids? What fixes ethyl methyl bad stuff? So we know that if they have respiratory acidosis, they need oxygen. Okay? Now, do we have a tool that's going to tell us what somebody's pH level is? No. Do we have a tool that's going to tell us what somebody's carbon dioxide level is? Yes. That's called capnography. Any cardiac or respiratory or trauma patient, you should always use capnography. Sir?
Will you use capnography over your O2 sat?
Yes. Because capnography tells us right now. O2 sat is trending. It was 2 minutes ago. Now, we should put the O2 sat on the patient we put a capnography on. But let's look at the capno number first. That's what really matters.
Could you also infer the O2 level based off of the carbon dioxide level?
You sure can. You sure can. So, capnography. Any question about what it is? It reads carbon dioxide levels in the body, or the ethyl methyls in the body. Oxygen fixes respiratory distress. All right? Respiratory failure, this is where things have stopped working. This is where the body is going, I'm tired, I'm weak. I can't breathe very well. And I'm not going to breathe very well because my muscles are now just full of acid. And I just can't. What do we need to do for that person? Yes, we got to breathe for them. How would we do that? Huh? Bag valve mask. You betcha. Now, do we want to just automatically run and get an eye gel and throw it in them? No. We want to start with our basics. Let's start with an OPA or an OPA. And if they don't tolerate an OPA or an oropharyngeal airway, then let's go to a nasopharyngeal airway. Which one do you have to lubricate? You have to lubricate the NPA because that's going to go into their nose. And it sounds traumatic, but any one of us in this room right now could put an put an NPA in yourself and you would have no problem with it. It would feel uncomfortable, but I'm not surprised.
I got one.
Just kidding you. Respiratory failure, it's a precursor to respiratory arrest because their body has stopped working. It said, I'm too tired. I don't want to breathe. So we put a non-rebreather or a nasal cannula on these people. Are they going to start breathing? No. We have to assist these people. Now there's another way that we can kind of assist them, and that's by using CPAP. It's continuous positive air pressure, which it's a mask that goes over their face, and they still have to be breathing to use this. If they're only breathing like 4 to 10 times a minute, we can't use CPAP. They have to be able to bring air in. But what happens with CPAP is it helps to hold open their airways, and it forces oxygen into their lungs. That in itself can help perfusion to get us reestablished.
If there's somebody in respiratory failure,
Yes.
but not distress.
With distress, we probably won't need to use it yet. Now, if they've gone too far into failure, is CPAP going to be beneficial? No. They're just too tired. They are just too worn out. A good way...
Try to CPAP for a VVM.
No. Tough question.
Depends on circumstance.
Yes. If they're only breathing 6 times a minute, CPAP's not going to work. If when they try to take a breath, it's just, even though they're breathing 20 times a minute, it's just that dead space air, CPAP's not going to work. They have to be able to bring air in, but we would just want to help push it the rest of the way in with the positive air pressure. Okay? It really is. Yes, it really is. Inadequate breathing occurs when a challenge is too great for the body's compensatory mechanisms. Rate of breathing, depth of breathing both fall outside of normal ranges. Recognition requires keen assessment skills and prompt action. Prompt action. When you look at somebody and you say they're pale, they're diaphoretic, and they're breathing too fast, what's the first thing we know they need? Oxygen. Don't be afraid to look at your partner and say, I need oxygen for this patient. Okay? You guys should be able to work well together like that. So you're going to first determine if the patient's breathing. Well, when do you start doing that? Yeah, as soon as you see them. If you walk in and they're slumped over and their head is down like this, and they're not moving, and the door is just slammed behind you, and they didn't even try to look up, do you think that they're awake? No. Could they not be breathing? Yes. Do we want to leave their head down like this? No. We want to bring it back in line, and then hopefully that will open their airway. Maybe that's what they need to start breathing better. Or maybe they're looking at you and they're saying, I can't breathe. Okay, we can make that assertion pretty quick, right? Signs of adequate breathing: equal expansion of their chest, good color, calm demeanor. Somebody that is air hungry is going to be attention hungry. They're going to be reaching at you, grabbing at you, trying to get your attention. And they're not trying to do it to be an ass. They're reaching at you and because they're begging you to help them. Signs of inadequate breathing. There's a change to their mental status. Somebody that's now a little confused, that's not normally confused. It might be hypoxia. Somebody that's just a little sweaty might be hypoxia. Somebody that isn't moving air freely, that you see the nice expansion of their chest. Or it looks like they're really tugging to try to breathe. Or they can only talk in short sentences, maybe 1 or 2 words at a time. Or maybe they can say, I just can't catch my breath very well. Is that somebody that's in distress? Yeah. What do they need? As soon as they say that to you, what do they need? Good. Breath sounds being absent or diminished. When somebody has asthma or lung diseases such as some cancers, some types of congestive heart failure, emphysema, they're going to get so tight around their alveoli that air doesn't actually escape them. It only escapes in micro amounts, or maybe none at all. Or maybe you only hear a wheeze or a rasp when they exhale. Or maybe you only hear bubbles on one side of their lung and not the other. Those are all definitive ways to kind of pinpoint what's wrong with our person. And we'll get there. We're not there today, but we'll get there. I do want to go back on this. Wheezing. Wheezing is that high-pitched whistly sound. All right? Stridor is a sound that you're going to hear that comes from up top. This has got to do with an airway obstruction or just some swelling of their airway. Cold weather will actually help it. And then you can have croup. With croup, you'll find it in children, toddler age, sometimes younger. The easiest treatments in the world for croup is cold weather. Normally, croup comes in the fall and very early spring, sometimes in the winter, but not normally, because winter is normally cold enough to kill off the virus. But what happens when you take the child outside in the cold is now the swelling that was pushing against their airway is now decreasing. So now what sounded every time they took a breath in and out, sounded like a seal barking, is now gone away. And they get to the ER or to their doctor's office and they're like, I swear to God, this is not how they were breathing a minute ago. And the doctor and the nurse will probably tell you, yep, you're absolutely right, I'm sure of it. Because they have croup. Gurgling there's two different types of gurgling. There's what's called rhonchi and rales. With rhonchi, it sounds like a really big bubble that's popping. You'll get that simultaneously with fevers, aspirations where somebody has swallowed something and it's instead of going into their esophagus, it went into their trachea. And that's the start of an infection. So that's what a rhonchi is. It's that big, wet bubble sound. A lot of times, just on one side. Wait, sir.
Is that like blowing truck or no?
Yeah, but doing it really slow and hard. Now, a rail or a rawl, the difference between that is it's a really fine bubble. It's like a little Rice Krispie snap, crackle, pop kind of sound. And that's going to be bilaterally or on both sides. And they're normally going to have some swelling or edema in their legs and or jugular vein distension. So how can we learn what these different sounds are? How can we learn that? How can we determine what we're hearing? Yeah. And when should we be listening with a stethoscope? How many people have a stethoscope you bring into class? A couple. Bring a stethoscope to class. If you don't have one or you can't get one, we got some extras. Every class, before we start, listen to breath sounds on each other. If you've got a little bit of a cough, tell your classmates, hey, I've got a little cough. Let's listen to them. Okay? Now, everybody stand up. When you listen to breath sounds, and my finger is the bell of your stethoscope, you're going to listen right here. Then you're going to listen right here. You're going to tell whether or not side to side it sounds the same. Why am I listening way up here? Everybody push on your chest right up here and tell me what you feel or don't feel. Do you have a lot of fatty tissue right there? No. The next place you're going to listen is up here in the armpit, on the side. I want you to take your finger and I want you to push gently right there and tell me what you don't feel. A lot of adipose tissue. And the next place that you're going to listen is the opposite armpit. And what are you listening for? Seeing if they sound the same on each side. The next place that you're going to listen is you're going to listen to the back, and it's going to be lower. And you're going to listen on one side and then listen on the other. Why do you do the front and the back? You're just listening to all aspects of their lung. So, here and here is because there's less what? Less adipose tissue or fatty tissue, and it's easier to hear. Back here, there's a little more adipose tissue, but we want to listen to see what we have at the basis. All right?
Listen to the lungs in the back.
I'm sorry?
You ever listen to the lungs in the back?
You can. You can. I teach this way simply so that you learn one specific pattern to use. Now, in 10 years, if I see you listening to breath sounds and you're listening to them a different way, I'm not going to chap your biscuit about it. If during class I see you doing it the way I didn't teach it, I'll probably chap your biscuit a little bit. When you do your clinical time, should you have a stethoscope with you? But you don't need that on the ambulance though, right? Do we need a stethoscope on the ambulance? Yes. When you do your ER time, do you need a stethoscope? What patient do we want to listen to breath sounds on that we encounter? What'd you say? What'd you say? All of them. If they have toe pain, listen to their breath sounds to get practice. That's the only reason. Okay, sit back down and relax. Now, inadequate breathing, this is where they're breathing either too slow or way too fast. And we kind of went through that. Do you understand how if you're breathing too fast, why we need to maybe overdrive breathe for them and start bagging them? We can actually slow their breathing down by bagging for them. Cyanosis is seen in the skin, lips, tongue, ears, or nails. Inspiration or expirations are prolonged. They're panting, or they're pushing, or they're really tugging to try to breathe. Patient not being able to speak, we talked about that. Retractions, this is where they have nasal flaring, or maybe even their neck muscles, they cave in, or it looks like their whole face goes in. Their chest may not expand like what you would expect it to. Now, oxygen saturation's reading low, below 95. If somebody has an O2 sat at 94, and the key number to remember for tests is that 94 number. So if they have an O2 sat of 92, does that tell us right away that they're having shortness of breath? No. It may actually be relatively normal for them. But if they have an O2 sat of 88 and they have a heart rate of 22, what do you think we should check? And when I say they have a heart rate of 22, it's because your pulse oximetry meters, they'll measure the pulse ox and the heart rate. So if it says they have an 86 pulse oximetry and a heart rate of 22, what should be the first thing that we check on our patient? Let's see if they truly have a heart rate of 22. If they don't, is our pulse oximetry reading right? No, it's inaccurate. Pulse oximetries can be inaccurate. Somebody with cold fingers, somebody with cold earlobes, somebody that's wearing nail polish, men or women, young or old, somebody that's got really thick fingernails, they're going to have poor pulse oximetry readings. If somebody's laying flat, is that a good position to be if you're short of breath? No. Because as you're laying flat, everything's kind of pushing up on your diaphragm. And if you're having troubles breathing, you need your diaphragm to work, don't you? Well, if you're laying flat, it can't do so. So people that are having shortness of breath, do you think they ever want to lie flat? Do you think you're going to find them lying flat? If they are laying flat, it's because they're in respiratory failure. They've just gotten too tired and too weak. Or they're not truly having a lot of respiratory distress. So if they're sitting upright or in what's called a tripod position, where they're sitting, maybe their hands are on their knees or they're bent forward and they're really tugging to try to breathe. That's a very common position for somebody that is air hungry to be in. Provide artificial ventilations to our non-breathing patient and the patients with inadequate breathing. What's inadequate breathing? Matthew, give me one example of inadequate breathing. Say again. Okay, they're breathing way too quick, like way over the spectrum, in the 50s. Would we all agree that that's inadequate breathing? Probably. If they don't have good rise and fall of their chest, that's inadequate. Parker, give me another example. It's an example of inadequate breathing. Say again. Okay, and that'll cause what? If your brain's not working, what's not happening? I kind of forgot what's not happening. What's your name again? I already know that. Well, hi, Zach. I haven't seen you in the last 20 years. Am I alert and oriented? Confusion. Okay? Who have I not called on? I've called on everybody, haven't I? Autumn, give me another one. Breathing too fast. How about breathing too slow? How about, we covered rate. What's another?
Skin color.
Okay, their color. What are normal skin colors? What's the normal skin color? Pink. Okay. Jack, what's an abnormal skin color? Okay, pallor. Jason? Okay. Cyanosis and ashen. Blue is cyanotic, ashen is gray. Okay? So we've got a couple. What are those three questions that we want to ask? Rate, depth, and quality. Positive pressure ventilation. I know we're covering a lot of stuff. Do you guys need another 5 minutes? Okay, let's take about another 5 to 10 minutes. Yes, sir?
You said a couple times when you use a CO2, it's 2 minutes behind. Is that just
For pulse oximetry.
Yeah. Is that? I mean, it's literal, or is that just? So if it's reading 92, that was takes
2
the
minutes
body
ago.
2 minutes to process everything down to that level. Okay.
So-
I didn't know if that was just kind of an example, or if that was literal.
No, that's literal.
Okay.
Yeah, it's delayed. Now, you might be 45 seconds for your body to do it. I might be 2.5 minutes. But the average
But
is
it's not an
a
instant.
2 minute.
Okay.
Yeah. Good question.
I didn't know that.
Yeah, no, that's a good question. Oh, yeah? Going back to work's always a good thing.
Probably.
Yeah.
So, finally.
Yeah, but now who's gonna run calls in Pulaski?
Right? Although his in-laws moved into a place, a nursing home, like a apartment or whatever.
Yeah.
Assisted living. And so he's up to Mason City, which is where they're from, taking the house back.
Yeah.
And it seems like he's gone quite a bit now too, so.
Well,
And then, not to mention, he'll run calls eventually. He works at the school and they let him go.
oh, good,
He said,
good.
now I'm going back to work, he's gonna run calls. He comes with me a lot anyway, and or Greg.
I heard you guys had a pretty decent trauma the other day.
Yeah. Was it yesterday?
What was that one?
Was it yesterday or the day before? I don't know. Cadence was telling me about
I'd
it.
have to look at the.
And I worked with her the night before, so, and that's when she told me about it. So it would have been the night before that,
Night, 2 nights ago?
On Sunday night?
I guess.
It was an accident.
Oh,
What-
yes.
What was it?
Yes, the accident, on, yes.
Yeah, and you didn't go.
Oh,
Yeah, I did.
yeah.
old
Oh, I was
boy
remember.
ejected.
Yeah. Oh,
Yeah.
yeah, he was, all I could tell you is I wasn't driving. Okay, sure.
That's all he would say.
A lot of things that happen during the day, if I'm at work, you're not listening.
No, I get that. I get it.
No, he was, I mean, he looked busted about it.
Oh, yeah, he was feeling it the next day, that's,
Yeah.
oh my goodness. Yeah. Yeah, interesting. That Crystal was down there and.
Yeah, it was
Cadence
a
and
whole
Bryson.
situation, right? There was something in, we were 18, wasn't working. so
Oh, yeah, I heard
all
something.
out.
Yeah, with an ambulance broke or something.
Yeah.
But then they
That
fixed it
happens.
like a minute later and they're banging around. So I don't know.
It happens.
I don't know what that was about.
It happens.
Did you see unplug it, let it back?
Yep.
Did you end up seeing the car in the ditch?
No, I sat in the ambulance and
It was,
Greg and,
it was me and Greg that.
oh, yeah, yeah.
Don't let Greg go down a hill.
Well,
It's easy getting down.
Oh, I know, but
Well,
it'll bring a hip
he
too.
didn't go down as far as I did. He just kind of.
That makes sense.
It's funny. I was telling Greg this too. It's funny when you,
Just remember, everything you guys are saying is being recorded right now. So,
when you go on a scene.
Larry, really cool.
yeah, yeah, thanks. She'll edit that out.
Larry is really awesome and,
I don't know.
What's that you were saying?
Oh, when you go on a scene, you get there and you listen. Like when we got there, Greg and I were right behind the cops, and they were asking some questions. And we come in, we ask them a lot of the same things again.
Mhm.
Our assessment is medically, not what the hell happened out there, right? Which is what the cops are concerned about. And then Crystal and her team comes in and asks us same line of questions again.
Yep.
Sometimes they go a little.
I don't know. All I know was I wasn't driving.
Yeah.
Every
It's a good answer.
single time.
I wasn't driving.
Well, and the curious thing with him was, like the right side of his face was all busted up, right? So we're trying to figure out if he's driving.
Yeah.
Typically, you expect either left side or frontal injury, right?
Mhm.
But not the right side.
His
Did
Left.
something fly up and hit him?
the car yawed when it was going down, and it looked to be like he ejected out of the back passenger windshield.
Oh,
So that would make sense why this.
Okay. Well, the other thing I would have thought is if you rolled it to the right and then fell all the way across the front passenger. But
Yeah, because the
Could be.
driver's seat wasn't buckled, but the passenger side was.
Yeah.
That was the weirdest.
Was it sitting in water? 'Cause the dude was soaked. He was like completely soaked.
yeah, I heard he
No,
really
it was
well.
actually elevated, but you could tell where a bunch of stuff was flying out the back window. I'm assuming he just then just
Went
you
with
know,
it.
Yeah.
You get right at soccer.
Yeah, go to the bathroom. I asked Cadence to bring me back a soda. Are they back yet?
Yeah, they came back, they just went to another call.
That little turd ball. Almost. Said something different that's being recorded. Yeah. The old man's getting tired. All right, you guys about ready to start up again? The temperature get better? You guys comfortable now? All right, Autumn, you didn't have to bring some for everybody. I'm just kidding. I'm just kidding. No. I was running late and I didn't stop and get one. And Diet Coke. Oh, unless they don't have Diet Coke, and then it's Diet whatever. Except Mountain Dew. I can't do Mountain Dew. That's back in the 80s, Mountain Dew, people did weird things with it. Just saying. Yeah, me too. All right, no you don't. No you don't. Okay, so positive pressure ventilation. What's that kind of sound like? We talked about it a little bit. CPAPs. So artificial ventilation is a huge use of positive pressure to force air or oxygen into the lungs. It can also be called just simply positive pressure ventilation. It's used when a patient has stopped breathing or has inadequate breathing. With specific positive pressure ventilation, that means that there's a button on the top of a tube or of a hose line that attaches to either a face mask or to an endotracheal tube, and they push the button and it forces air in. When you let off of the button, then the air comes back out because you positively force air into the lung, it expands. When you let go, the air comes back out. What do you think a problem with that device would be? Give them too much air. And if your lungs can only expand so far, what's going to happen if you overinflate their lungs? It's going to cause a bleb. Who do you think it's going to be the most dangerous to use on? Children or infants? So you don't see this very often at all. Use of positive pressure has negative side effects. Cardiac output and blood pressure drop because the heart's ability to fill its chambers is affected. Because you overinflate the lungs, guess what it does to the heart? Remember our 3-person demonstration where you start pushing and the heart gets pushed? Remember us doing that right there? Gastric distension occurs. Yes, you wind up forcing air not only into their lungs but also down into their stomach cavity. And as their stomach cavity starts to fill up and it becomes overly full, where do you think that air is going to come? It's going to start to come back up. And what do you think it's going to bring with it? All the stomach contents. So there's 3 methods. Mouth to mask. Do we do mouth to mask? If we have all of our equipment, let's use it. Let's use a bag valve mask. Let's ventilate with oxygen. So there's not much need for us to do mouth to mask. Now, say you're walking through Walmart. Somebody collapses right in front of you. Maybe it's your grandma. Are you going to do mouth to mouth or mouth to mask for her? Yeah, most people would, unless you're in the will. And then, oh, come on, Matthew, that had some humor in it. 2 rescuer bag valve mask ventilation. When you have somebody that's got really small hands, they may need to be one person holding the mask so it creates a nice tight seal around the patient's mouth while another person is bagging. For the majority of people, you can do the C shape and hold the mask with a nice tight seal. And you're just going to collapse the bag. You collapse it only far enough that you see what happened. Chest rise and fall. Never ventilate a patient who is vomiting or has vomitus in the airway, because if it goes into the lungs, it'll cause aspiration pneumonias. Good job, Cameron. To ensure adequate ventilations, watch the chest rise and fall. Ensure that the rate of ventilation is sufficient. What's the normal rate? For adults, right? So if we're ventilating somebody, how many times are we going to try to bag them? About once every 5 seconds, maybe 6 seconds. An infant or a child, once every 2 to 3 seconds. So we've got this patient. How do we know to breathe 12, 13, 14, 15, or 20 breaths a minute? There's a couple tools that we have. Okay, but if you don't know the person, how would you know that? Okay, you can watch their chest rise and fall, but does that tell you how many times you have to breathe for them? What did you say? Maybe their size. What do you say, Tanner? There's 2 really good devices that we've talked about. Say again? How about pulse oximetry and end tidal? If we're bagging somebody, we're breathing for them, what do we want their pulse oximetry reading to read? We're trying to get it to 94. If it goes higher, is that a good thing? But is that a true number for us? What tells us what's happening right now? Capnography, end tidal CO2. So,
Isn't that based on the breath though?
you're breathing for them. So the air's going in, it's going through its entire process. Alveolar capillary exchange is happening. And when you let off of the bag, what does their lung do? Collapses down and air comes out. And as the air comes out, that tube will read what their end tidal CO2 is.
So it's not, so what I'm thinking of is the one that goes across, but there must be another way to read it.
There's 2 different ways. If we're bagging somebody, we're going to use the one that you will put on the end of the bag. If we're just have a non-rebreather or a nasal cannula on somebody, we're going to use the one that sits right below their nose. Now, if they stop breathing, we can still use that one as we're bagging them. It'll still read it. So we're going to bag them adequately enough so that we get an end tidal that falls between what 2 sets of numbers? 35 and 45. And we want their oxygen level to be above 94. So if that means we're breathing for them 10 times per minute and we have those numbers, is that a good thing? Yeah. What if we're breathing 24 times to get those numbers? Still a good thing. Oh, let's see. Techniques should always ensure adequate protection from the patient's body fluids. Make sure that we always have our BSI or PPE in place. If there's a chance that they're going to vomit, make sure that we have our eyes protected, our face protected. Ventilating a patient who is breathing rapidly, this is where we're going to try to overdrive breathe for them. We still need to hold a good seal. We need to do a lot of communicating, because are they used to having something over their face? No. So we want to do it slowly, introduce it gently. Once we get it up to their face, then we're just going to help bag slowly. And all we're trying to do is break that pattern that they're in. All right? Should we still do capnography? Should we still do pulse oximetry? After the seal of the mask is over the face, squeeze the bag for the patient's inhalation. Adjust your rate over the next few breaths so that you can ventilate fewer and fewer times. Carefully assess adequacy of respiration. Well, that's, do we see the chest rise and fall? That's looking at our numbers on capnography. That's checking our pulse oximetry. Okay? That's looking at their skin color. When we open the airway, well, there's a couple different ways to do it. Do we have to maybe suction out their airway? Possibly. Are we going to maybe do a head tilt, chin lift? If it's a medical patient. What if it's a trauma patient or we don't know? Modified jaw thrust. Remember, hold that C shape to create a seal over their face. It's another good idea to take the mask in your hand, bend it open, set it down over their face so that when it collapses back, it creates a little bit of its own suction. Large bushy beards. Well, can we use like KY jelly? Goop up their beard? We can. Can we use petroleum jelly? No.
Okay, that's petroleum based.
Yeah, petroleum-based jellies we can't use. KY jelly is water soluble. So we can use a water soluble jelly. It's not just for sex anymore. Dentures. Why do we want to leave their dentures in place? You bet. Without the denture, their mouth opening or their oropharynx can be distorted and it's hard to get it sealed in. Raising the patient's head. This is one that really is beneficial because it just puts their head in a natural alignment for air to go in and out. At about a 30-degree elevation, which is basically like a pillow. Mouth to mask ventilations. Any question about how we do that? You're just ventilating just like a bag valve mask, but instead of having a bag valve, you're using your own. Why would we do this over a bag valve mask? We wouldn't. If the bag valve mask is available, we're always going to use that. If we don't have one available, then we have to look to something like this. Okay, so this is a one-wave CPR mask or a ventilation mask. If you notice on the top, this is a filter so that air will go in, but bad stuff will not come back out. So the ooey gooey, sticky, stinky, wet, and not your stuff will not come up through that filter. Oh, I went too far. Okay, so if we believe that our patient has a spinal injury, we're going to be directly above their head because we want to make sure that we can maintain stability of their neck. All right? Place the patient in a head elevated sniffing type position, which is like that 30-degree angle. Apply the mask. Thumb sides are what you're going to hold down on. You're going to lift the angle of the jaw. If you try to do this on another person that's awake or yourself, it will hurt. So don't try to do a modified jaw thrust on somebody awake. The back valve mask itself, it will keep the ooey gooey, sticky, stanky, wet stuff away from you. They come adult and child and infant sizes. We can actually use a child size back valve mask even on a small adult. Because what we're looking for is just to squeeze the mask hard enough to see rise and fall of their chest. It may not be squeezing it completely down. The reservoir bag that's on the back, we should have it going at least 10 to 12 liters of oxygen. If every time we squeeze down, that bag empties, what do we need to do? Well, we need to increase the oxygen because we want to make sure we're giving them the highest level of oxygen we can. We'll learn this in a practical station. Okay, with stomas. Anybody know what a stoma is? Yeah, it's right here. What they do is they insert a trach tube down through the stoma. If a person that they no longer need the trach tube because this is all calcified or hardened, then they can pull that out and the person can still breathe through the stoma opening. They may still even breathe through their mouth some. But a lot of times if they do have the trachea, that's where they're breathing from. They're not breathing out of their mouth or their nose. We're going to bag it just like we would endotracheal tube. We want to use caution when we push the bag onto it or pull the bag off of it. Because it's easy to push it too far in and damage their trachea or pull it out as we're trying to unplug it. So use gentle hands when we're attaching or pulling the bag off of a tracheal tube. So if we improperly ventilate somebody, too slow or too fast, are we oxygenating them correctly? No, we can actually cause brain swelling. So if we hyperventilate somebody that's in cardiac arrest just from, okay, our nerves and our adrenaline is up, and boy, we're just bagging away, we can actually cause their brain to swell and create an infarct in their brain. So we want to be really cautious when we bag somebody. If we squeeze too hard or too much, where we're overinflating and their chest is now really expanded, we're also pushing air into their gastric contents. What's going to happen? Everything's going to come right back up and out. When you squeeze the bag, it's a nice, firm, solid squeeze. You don't want to pump hard on it or just too lightly. It's a nice, consistent squeeze. This is a portable ventilator. It's a pre-hospital ventilator that is way outdated. So supplemental oxygen. Why do people need it? Say again? Well, you need oxygen to create energy, but why do they need supplemental oxygen? Okay, maybe their body is not circulating enough. We've got damage to either the circulatory system, the pump, or our lungs. Okay? So that's why we use oxygen with people. If they have too much buildup of ethyl methyls, maybe everything is still intact, but they've worked so hard that they've created additional ethyl methyls that are circulating. Why does the football player on the sideline go over and start hitting on an oxygen mask? Why do they do that? Go ahead. Yeah. Their muscles have been overused. They got this buildup of lactic acids. They're taking the hit of the oxygen to help try to resolve that buildup, to neutralize those acids. So people that got more muscles, Arnold Schwarzenegger, he needs more oxygen to produce energy. And the more energy he produces, the more lactic acids he's going to build. So he needs to, or lactic and pyruvics. So he needs to have more oxygen. Okay, so oxygen, it can cause damage to the heart, a heart attack in stroke patients. That's really hard for me to say, because if somebody is having pain, oxygen is the first treatment for pain. They can tolerate low doses of oxygen as long as they don't have inadequate breathing. They can tolerate even moderate doses of oxygen. So you have the person that's telling you, I have chest pain, it feels like somebody's sitting on my chest. It's okay to give them oxygen. Now, do we want to just automatically go for 15 liters? No. But if we see that they're diaphoretic and they're pale, do we want to go for 15 liters? Probably want to go at least 10 and see, does the bag deflate completely? If it does, we need to kick it up some and monitor their respiratory rate. Too much oxygen circulating in the blood flow can cause brain swelling. Just like I said, if we hyperventilate somebody, we can cause the brain to swell and it cause an infarct inside their brain. So that's why they kind of talk about it can be harmful. I don't want you guys to automatically think, well, I can't use it on a heart attack or a stroke. That's not true. Oxygen is a drug. So if you see somebody ask on a test or a clinician asks you what's the first drug you gave, it should be oxygen. Oxygen administration is based on the evaluation of a saturation of 94%. Remember, I told you that's that key number. We want everything to be lightweight, easily moved. We got away from steel tanks just because of how heavy they are. Now they're aluminum. We have to take caution in the way we carry them. When we're using an O2 tank, do we ever want to set it straight up and down like that bottle right there? No, because what could happen? Knocked over, and what could happen to the joint at the top? And if it gets damaged, where's that tank going? You betcha. It will take off like a jet engine. Was walking through a cornfield in Mount Zion for a farmer that had part of his arm pinned by a bean head. trying to get the bean head lifted up so that we could get his arm out. We had him on oxygen. He's in a lot of discomfort. He's breathing kind of hard. Well, we don't have a main O2 tank out in the middle of the field. So we were using a portable. Portable started getting low. I said to my partner, Ann, will you go grab another O2 tank and bring it up here? Well, the way that she would walk normally is she had, you know, a lot of arms swooshing, and she was doing that as she was walking with this tank. And all of a sudden, this tank just takes off right out of her hand and goes flying through the cornfield. And I said to her, I said, Ann, but did you drop it? No, I didn't. I'm thinking, okay, she just doesn't want to admit she dropped it, whatever. Nobody got hurt. It's not that big a deal. Forget about it. So we got another O2 tank, changed it out, dealt with the farmer. He was all taken care of. He was great, good to go. We get to the hospital probably an hour, maybe 2 hours later. And I open up the cabinet door to change out the O2 tank again. And I reach in and grab a hold of it, and it is hot. And I look at the regulator, and it's showing that, or after I put the regulator on it, I look at it, and it's nowhere near the 2000 mark. It was redlined all the way to the right. What had happened is the inverter on that ambulance was in the same cabinet as the O2 tanks, and the inverter got left on, and it kept heating up those tanks. Right, Matt? And it just kept heating up those tanks. And as the tank got hotter and hotter and hotter, the air got compressed, and then all of a sudden it shot off through the field. She didn't drop it. It was just the movement of the tank caused it to happen. So the types of cylinders we have, D cylinders, 350 liters of oxygen. That's what we normally carry inside the ambulance for our portables. E cylinders, they're taller and slenderer. You may see those in some ambulances. A lot of times you'll see them underneath the cart of the cot in the hospital. M cylinder, that's a onboard tank. It's pretty decent sized. It's not the biggest. The K cylinder is actually a little bit bigger than the M cylinder. And then G and H's we won't ever carry. This is an example of an onboard cylinder. When we get into doing our practicals, we'll actually go out and change out one of these tanks, and everybody will do it. You'll see the way to move a tank from one spot to the other, how to mark it as empty, how to mark it as full. Each different ambulance is going to be a little bit different. So it's something that if you're on a truck that you've never worked on before, or it's one that you're not used to being on, look at it before you go trying to change it out. Cylinder safety, this is always important. We want to lay it on its side, especially not putting it on a table or an elevated platform, trying to keep it on the ground if we can. Protect it from heat and extreme colds. We don't want to use oils on it. There's a little O-ring that we want to make sure is always in place and it's not collapsed or crushed down too far. We want to make sure that it's quality grade oxygen, not just, we have a, God dang it, what do they call them in the fire service that we fill our bottles with? Say it again. Yeah, what's the machine we? Okay, I mean there's an actual term for it, but I can't think. Cascade, thank you. We want to make sure that we're not just filling it with a cascade system. It needs to be purified oxygen. Always open the valve fully, then close it halfway turn so that you know that the valve is functioning. You Yes, the tanks need to be tested hydrostatically every 5 years. Whoever your supplier is will do that for you. If you drop the cylinder, you could have a problem. Never leave oxygen cylinders standing upright. Never allow smoking around oxygen equipment. Don't use greases or oils. Never use adhesive tapes on the cylinders, and never try to move an oxygen cylinder by dragging it or rolling it on its side or its bottom. Just an example, this is actually a D cylinder. Pressure regulator may be connected to a cylinder, provide safe working pressures, 30 to 70 psi's. On E cylinder size or smaller, regulator secured using a yoke assembly, and we'll show you that. Anything bigger than an E cylinder, you have to thread the regulator to it. Flow meters, we'll go over that when we sit down and do one of these practicals. It's going to show you the pressure inside of the tank, as well as on the side of it, you'll be able to turn the number of liters that you want to come out. This regulator will tell you what pressure you have inside of the tank. This is where you'll adjust it as far as to be able to tell how many liters are coming out of the nipple that'll be right about here. This will be hanging on the wall. Notice it's threaded in because it's one that's on a higher concentration tank. There'll be a little bulb here that'll come up, and you just turn this knob to bring that bulb up. If you screw in a pressure line here, all that'll do is when you turn the tank on, it'll open up a positive pressure coming out of this line here. It won't go through this nipple. A lot of times we were using this on CPAPs. Went through a lot of oxygen that way. Humidifiers can be attached. All that means is that the oxygen that's inside of the tank is very dry. It can cause people to get nosebleeds if they're on it for a long period of time. So it's just flushing it through a container of water. And as the oxygen goes down into the water, it picks up water molecules and just hydrates it. This is an example of a humidifier. It'll attach to your wall units. Depending on the size of the humidifier, most of them are only going to be like the size of a carton of milk. Some of them you can get pretty tall. Let's see. Talked about those things. Yes, we can have toxicity from oxygen, and that's just where you have, say, a baby that's in a enclosed capsule, and there's nothing but oxygen flowing inside. What'll wind up happening is the red blood cells will be so saturated with oxygen that it'll collapse the alveoli. Eye damage is very possible if we blow oxygen directly into an infant's eyes. Also, if we blow oxygen directly into someone's eyes, it can stimulate what's called a vagus nerve. And if we stimulate the vagus nerve, we cause their blood pressure to go down, their heart rate to go down, and their respiratory rate to go down. If you think about it, when you've been stressed, what's one thing that a lot of people will do? They get stressed out and they just kind of, oh my God. Just kind of put pressure. Did you know that that's what causes your heart rate to go down and your respiratory rate to go down, your blood pressure to go down? Your body did. That's why you do that. But by blowing oxygen into their face, it'll cause the same problem. Respiratory depression or respiratory arrest occur with hypoxic drive in a depressed COPD patient. Remember, we talked about if they need oxygen, we're giving it to them. If their respiratory drive goes out, it was probably going to happen anyway. This is after long periods of oxygen exposure, not just a matter of 15, 20 minutes that we're with them. There's a multitude of different devices, and we'll go through the various different ones for you. As far as nasal cannulas, these are used for mild dyspnea or mild shortness of breath. It just will deliver a few liters to their nose. We want to make sure that the prongs are actually facing downward as we put them in. So the prong itself will be facing up, but we want it to point back to the back of their nasal passage. Moderate distress, high concentrations of oxygen using a partial non-rebreather. Partial non-rebreathers are nothing more than a mask that goes over their face. And on one side, there's a rubber O-ring that covers a hole. On a complete non-rebreather, there's a rubber ring on both sides. So that as they take a breath, it pulls that rubber ring down, so all they're breathing in is the oxygen coming out of the mask. Partial, they're bringing in a little bit of atmospheric air. The reason that a partial is better than a non-rebreather, it takes away the chances of having oxygen toxicity.
Are you able to change to pull one of those out if they're not using it?
The only ones that we're going to have are partials. Non-rebreather mask, best way to deliver high concentrations of oxygen to patients that are breathing. We want to make sure that their rate, depth, and quality is adequate before we start giving them just a non-rebreather. If they're only breathing 5 times a minute, is a non-rebreather going to do much for them? If they're only moving air to the dead space, is a non-rebreather going to do much for them? No. Make sure we inflate the reservoir bag before putting it over the patient. And as the patient's breathing, we want to watch to make sure that the reservoir bag doesn't collapse down all the way. Let's see. Patients with chest pain, we're going to use whatever oxygen device we find appropriate. If you feel that you just want to give them a little bit of oxygen to try to make their pain a little more subtle, let's just use a cannula. If they're having crushing chest pain and it's hard for them to take a breath, but they're moving air completely down in their lungs, can we use a non-rebreather? Yeah. Come on. Cannulas, low concentration of oxygen. This is something to know, 22 to 44%. Cannulas, we don't ever want to get over 6 liters. With some patients, you get to the 5 or 6 liter mark and you'll hear a whistly sound. Turn the O2 down a little bit. It's what's happening is it's blowing too hard into their nasal cavity, and you'll cause a nosebleed. Again, if your patient doesn't want to wear an O2 mask, at least give them a cannula. A lot of people that are having troubles breathing, they do not want to put anything over their face. Partial non-rebreather is what you'll see that we use all the time. It's the one that just has the one rubber ring to the outside of it. There is a one-way valve like a non-rebreather mask. It allows the patient to rebreathe about 1/3 of exhaled air. It's useful to preserve carbon dioxide levels to stimulate breathing. Mask will deliver 40 to 60% oxygen levels at 9 to 10 liters per minute. If we're at 9 liters and the bag stays inflated, is that good? If we're at 9 liters and the bag collapses down, what do we need to do? Up it. Venturi mask, this is one where we used to use Venturi masks a lot on COPD patients or asthmatics, a lot with kids that had croup or striders. It's meant to deliver a more specific percentage of oxygen. It's got openings to both sides of it, and it's a complete open hole. It has a little plug that goes underneath that will limit the amount of oxygen that comes up to a very specific amount. We don't use them very often any longer, though. Tracheostomy mask. This is one that looks very similar to a non-rebreather, except it doesn't have a reservoir bag, and it's more of like a oblong shape of a football, and it just sits over the top of the tracheostomy, and it has the strap that'll go around their neck. Its purpose is just to try to increase the level of oxygen that they're getting. Normally, you're going to run at 8 to 12 liters, or I'm sorry, 8 to 10 liters. If they stay dyspneic or if they stay with low pulse oximetry, what should you do? Up the O2. High concentration of oxygen administered to children in respiratory distress with inadequate respirations. Illnesses in children, and this should be in your notes, and you should remember this. 90 to 95% of illness in children that is life-threatening is lack of oxygen or ventilation. (90 to 95% of sick kids that have life threats is respiratory related. I'm sorry? I didn't hear what you said.
This chapter is making me feel like I have curiosity.
No, don't do that. No, really don't do that. Okay, so children, do you think that they like to have masks put over their face? We're going to do something called blow by. What that is we're just going to hold it a few inches away from their face. Start by coming across from the side, maybe up from the bottom. And you just want to hold it a little ways away from their face. Don't try to force it on them, but get it up to about 2 inches away, and every breath they take, they're going to be bringing in extra oxygen. Less scary for them. If they want to hold it, let them hold it. But if they're going to hold it, make sure that you or mom or dad or caregiver has a hold of it too, so that we kind of keep it in the same area. Facial injuries, another problem when we try to create a seal. Am I going too quick? Same with somebody that's got a big bushy beard. If we got a lot of blood or broken teeth or vomitus, it's going to be hard to create a good seal or for a patent airway to always be present. What's a patent airway? It's open. Obstructions, we want to suction so that we adequately remove any solid objects. We can use whistle tip, we can use a rigid tip or a Yankor. Using a Yankor in the oral cavity is best. Do we ever want to stick a whistle tip down somebody's nose that has facial trauma? No, because we could actually penetrate the brain. Dental appliances, we want to make sure they stay in place like we said. Infants and children, remember their tongue takes up a huge amount of their oral cavity. If we have to place an oral airway, let's put one in. Are we ever going to put a nasal airway in an infant? No. Trachea is softer, more pliable, more flexible, and the head is proportionately larger for an infant. Chest wall is softer. Diaphragm breathing is more important. Oxygen burn rate is twice that of an adult. That's why these little guys will breathe a lot faster. Everybody's trachea has cartilaginous rings around it. You remember talking about that in anatomy? In infants and young children up into toddler years, those cartilaginous rings, they don't solidify or harden. They're still soft and pliable. So as their muscle and neck tissues start to swell, it pushes their trachea closed. So now when they take a breath in or out, it's all right up here in the top of their trachea, and it gives that whoopy, barky kind of sound. That's called croup. Why do they put them outside? Why does that take the croup away? Reduces the swelling. How about if we put them in a bathroom with a hot shower running? The steam will actually go through and loosen up some of the airway and decrease some of the swelling as well. Avoid excessive pressures and volumes. Remember, their lungs are a lot smaller and they're easily popped or blebbed. Use pediatric-sized masks and cannulas when appropriate. Gastric distension will impair adequate ventilation because what do they need to breathe? Their what muscles? Their diaphragm and their abdominal muscles. Assisting with advanced airway devices. This is one that we'll show you guys. You guys will not ever intubate a patient, but we may ask you to retrieve intubation equipment, and we'll want you to know what all of that equipment is, whether it be a bougie, whether it be a stylet, or the endotracheal tube, cuffed, uncuffed. Those are all things that we may ask you to retrieve for us. We may even look at you and say, hey, I need you to grab out the Miller blade and laryngoscope, an 8.0 tube holder, stylet. What are you going to grab? Right now, I ain't got a clue. What are you talking about? Yeah, you want to stop speaking Chinese and tell me what the hell you want? So you're going to learn what each one of these are. Now, you're not going to be the person that puts the tube in. We'll let you intubate in class just so you experience it, but you will not do it on a real person. You will not do it on a real person. This is an endotracheal tube being passed. I would say that this person is probably just a picture and not a real patient, because you're not going to hold the laryngoscope like this and you just won't get visualization. Once the tube is placed, paramedic assures proper placement by two methods. Those two methods are going to be listening to breath sounds, and then a secondary method, whether it be capnography or a colorimetric changing device. There's a multitude of different things. We're going to be listening to make sure that there's no epigastric sounds. Take care not to disturb the tube. Very little movement of a patient that has an endotracheal tube in place can cause the tube to dislodge. So if you're the person that's bagging and you're holding on, and the tube is in place and you're bagging and you're driving, oh, bump, what might have just happened? You may have pulled it out. Even though you're like, oh, well, no, it went right back down to where it was. Make sure that you communicate that. Hey, it may have just dislodged the tube, because we don't want to walk through the door with an endotracheal tube that's dislodged because we hit a bump. Resistance to ventilations. If we're bagging and we get resistance to trying to bag, it's really hard. There's a good chance that the tube's not in the lung, or if it is in the lung, that there's some kind of mass that's keeping us from being able to ventilate. So that mass may be blood, it may be air, it may be infection. There's a lot of things that it could be, but you need to voice that if you're the person that's bagging. You need to say, hey, it's getting harder for me to bag. And the paramedic will then in turn try to figure out why that's the case. Changes in the patient's mental status is always important. If we're tubing somebody, they're most likely going to be unconscious, either because they were unconscious or we put them unconscious. Provide manual inline stabilization. That's just where you're holding their head still so that we're not manipulating their neck. You'll stabilize the head from the patient's side. Paramedic will lean back, use laryngoscope and tube placement. Still, the tube's got to be anchored in. Hold manual stabilization. So, on our syllabus, can somebody pull up the syllabus real quick or pull it out? Thank you, man. Okay. Monday is when we'll do a lot of these skills. I just wanted to make sure I wasn't supposed to do some of them tonight. A lot of information. How can we tell if somebody is short of breath? Do we need tools and toys? No, Jack, what are you saying? Look at them. If we're looking at them and we think, that person looks sick. Are they sick? Yeah. If somebody looks hurt, are they hurt? Yeah, until we can prove otherwise. If you look at somebody and you think, hey, they need oxygen. What do they need? Until we can prove otherwise. Is oxygen in some cases contraindicated, especially over long-term periods, because we worry about getting oxygen intoxication or oxygen toxicity. It's not a very common thing, and it won't happen in this short period of time that we're with our patient. Okay? I want to make sure we clarify that. What's ethyl methyl bad stuff? Waste products. Give me an example of some waste products. Anybody? Carbon dioxide. Lactic acid. Pyruvic acids. Cations. Okay? What's the treatment for respiratory acidosis? Yeah, because our body is normally acidic or alkalytic. It's alkalytic because what's our pH level? 7.35 to 7.45. What's a normal biox reading or pulse oximetry reading? 94%. Biox is an old school term. Shut up, I am old. I got an eye roll and a, so if it's above 94%, is that good? Yeah. Can a little bit of oxygen help even if it's 94% or higher? Yeah. Helps take away pain. A lot of pain is caused by buildup of acids. What if they have a end-tidal reading of 22, a pulse oximetry reading of 100, and a respiratory rate of us bagging them of 28? They have an end-tidal CO2 reading of 22. They have a pulse oximetry of 100%. Yeah, we need to slow our breathing down because we have breathed off too much carbon dioxide. We've delivered too much oxygen. And what will that do to somebody's brain?
Let me see here.
Okay.
Can you explain the chemo receptors again?
Yeah. Chemoreceptors are located all throughout your body and your vascular system.
Okay.
What they do is they read the amount of carbon dioxide and or oxygen that's circulating in your blood. And those they send a message to your brain and say, hey, I got too much carbon dioxide up here. I need more oxygen.
Okay.
So your brain then kicks in and says, hey, send a message down to the lungs, breathe more.
Okay.
Okay?
Yep.
So that's what chemoreceptors are.
Okay, all right.
Good
'Cause I
question.
have send alert that we need